Okay, so for the second part of the metabolism regulatory concepts, we are going to focus on the pathophysiology of the thyroid. The thyroid is a shield-shaped structure. Some people also say it's a butterfly-shaped structure that is located right below the larynx in the anterior middle of the neck. The follicles are the functional unit of the thyroid, and they're filled with thyroglobulin, which contains tyrosine amino acids. I provided a couple videos for you to watch. They are for patient education, but I think they provide a great basic understanding that might help you. So for hormone synthesis in the thyroid, iodide attaches to the tyrosine molecules, right? So this is why people need to consume iodide or iodine in their diets. We really only need a small amount because the thyroid is super efficient in using it. So if you're ever wondering why they sell salt that is iodized, this is why. This was the US's way of helping prevent thyroid disorder. The next thing is thyroid peroxidase, which is termed TPO. This is an enzyme that's going to oxidize the iodide. So the oxidizing reaction helps combine the iodide and tyrosine to form monoiodidotyrosine, or MIT. When a second iodide is attached to the MIT, it becomes diiodotyrosine. This is important to know because when you look at the thyroid hormones, thyroxine, or T4, is actually two diodotyrosines coupled together. That's why it's called T4. Whereas triiodothyronine, or T3, is a DIT and a DIT coupled together. So 2 plus 1 is 3. If you look at what is in the circulation, right, it is T3 and T4. That is all that's released into blood circulation. 90% of that being T4 and the remaining 10% being T3. Both T3 and T4 have to be carried by binding proteins. The function of T3 is metabolism, protein synthesis, cardiorespiratory function, GI function, neuromuscular effects, and growth and development in children that include both mental development and sexual maturity. T4 is actually an inactive T4 is inactive until converted into T3 in the tissue. So really T4 has no functions. It's just the form of stored T3, if that makes sense. It's only T3 that produces function. So thyroid hormones are regulated through the hypothalamic pituitary thyroid feedback system. That's a mouthful. Basically, when thyroid hormone levels are low, the hypothalamus releases TRH, which is thyrotropin-releasing hormone. So things that might cause this are cold exposure. It's actually one of the strongest stimuli. And then stress and sleep are also stimuli. Right, so you have this stimuli, and it tells the hypothalamus, we need thyroid hormone, our levels are low. And the hypothalamus reacts by releasing TRH. The TRH then stimulates the anterior pituitary to release thyroid stimulating hormone, or TSH. Right? What do you think TSH, or thyroid stimulating hormone, is going to do? It is going to bind to the TSH receptors in the thyroid gland and it is going to stimulate the thyroid, right? Thyroid stimulating, clever name, to start doing its job. The thyroid then releases T3 and T4 into circulation to travel to target tissues. And again, it's this loop feedback system, so the elevated amounts of T3 and T4 in circulation actually go and inhibit either the TRH or the TSH from being secreted. There are a few tests that measure thyroid function. We'll talk more in detail about some of these when we talk about the specific disorders, but in general, serum tests to look at T3, T4, and TSH levels. These are usually the go-to tests for thyroid function. And then there's certain thyroid antibodies, for example, anti-TPO, and these are seen in Hashimoto's thyroiditis, which we will talk about. Then there's radioiodine 123I reuptake test. This is going to measure the ability of the thyroid gland to remove and concentrate iodine from the blood. Different imaging such as thyroid scans, ultrasound, CT, and MRI to see the function of the gland. And then there's fine needle aspiration biopsy that looks at things like cancer. Here's a list of some of the common thyroid disorders, right? There's hypothyroidism, which can either be congenital or acquired. Acquired could sometimes be Hashimoto thyroiditis or because of a thyroidectomy. And then there's hyperthyroidism or thyrotoxicosis. And some examples of this would be Graves' disease and thyroid tumors. Another thyroid disorder is a goiter, which is a generalized enlargement of the thyroid gland. It can occur with either under or over stimulus of the thyroid hormone, right? The most common cause is iodine deficiency, but not in the US. Because again, we add iodine to salt, and let's face it, Americans get more than their recommended or daily needed salt intakes. So a goiter is basically related to excess TSH. And as I mentioned, it can be present with either hypo or hyperthyroidism. So what happens is when the pituitary gland senses that the thyroid is not producing enough thyroid hormone, it sends out TSH to stimulate the thyroid. But when the thyroid is not producing hormone, the thyroid gland grows, right? It's a compensatory mechanism. We need to grow, we need to make more hormone, and this is going to result in a goiter. Another disorder is thyroid nodules, which are localized enlargements of the thyroid gland. So with the goiter, you see this diffuse enlargement. With the nodules, it's just in one area, and they can either be benign or malignant, with malignant being the least common. They are usually benign. The problem with these and the problem with a goiter is they can compress the trachea. So if untreated, unmanaged, it could cause some pretty serious damage. They're evaluated using ultrasound, CT, MRI, and ultrasound-guided fine needle aspiration. And finally, we have thyroiditis, which is an inflammatory disorder. Some causes could be viral, bacterial, fungal, or a chronic autoimmune, such as Hashimoto's. Another cause actually is pregnancy. So you see a lot of women develop pregnancy-induced thyroiditis after the baby is delivered, but that usually goes away in a few months. So here's a question for you, true or false? Goiters are always associated with increased production of thyroid hormone. All right, the answer is false, right? Remember, goiters can occur in hypo, hyperthyroid, and even euthyroid state. Euthyroid is just the fancy term for a normal functioning thyroid. Let's talk a little bit more about congenital hypothyroidism. This develops prenatally, right? So it happens in utero, and then it's going to be presented at birth. It may result from a lack of a thyroid, abnormal biosynthesis of thyroid hormone, or deficient TSH secretion. Now remember, the thyroid hormone is needed for growth and brain development. So if left untreated, this is going to result in mental retardation and impaired physical growth. Some signs and symptoms. So right at birth, the infant's going to appear normal. And the reason behind this is because mom supplied the hormones in utero. Right, so the baby still has some of mom's hormone in them as well, so they usually wait 24 to 48 hours to test this. But some signs and symptoms, the first sign usually is going to be prolonged jaundice. You might see respiratory difficulty, a hoarse cry, enlarged tongue, which is part of the reason for the respiratory difficulty. Feeding difficulty, also related to the tongue. Sluggishness, lack of interest in feeding, somnolence, and choking during nursing. Again, because of that enlarged tongue. An enlarged abdomen, and even an umbilical hernia. And this is just a picture of an infant born with congenital hypothyroidism. If you notice, they've got that enlarged abdomen. It looks like they've got a hernia, and their skin is yellow or jaundiced. So a term you might hear is cretinism. And cretinism is a term used for untreated congenital hypothyroidism. It is not used for babies who have treatment initiated shortly after birth. Most developed countries, such as the US, do screen newborns for hypothyroidism because research studies have shown that if you closely monitor T4 supplementation, and it's begun in the first 6 weeks of life, it results in normal intelligence. So you want to monitor, you want to diagnose it, and you want to start treatment quickly before there is any lasting effects. Screening is done by blood tests, so they measure T4 and TSH, and they do this 24 to 48 hours after birth. And it's done by a heel stick. They just need a drop of blood. Treatment is going to be hormone replacement for life, and the dose is going to need to be frequently adjusted as the child grows. Acquired hypothyroidism is going to develop later on in life. And then there's primary versus secondary hypothyroidism. Primary results from disease of the thyroid gland. Some possible causes, it could be autoimmune, such as Hashimoto's thyroiditis. This is the #1 cause in the US. Iodine deficiency is in the #1 cause in underdeveloped or developing countries. Another cause is a thyroidectomy or ablation of the gland with radiation. Certain medications, such as lithium and antithyroid drugs, can cause a goiter, which can lead to hypothyroidism. Large amounts of iodine or not enough iodine. And then subacute thyroiditis. And this is that one I was telling you about with the pregnancy, postpartum, the mom will develop it. This happens in about 10% of pregnancies. Whereas secondary hypothyroidism is caused by a disorder of the hypothalamus or pituitary gland. So the thyroid gland itself is normal. A little more about Hashimoto thyroiditis because it is the #1 cause of hypothyroidism in the US. It's an autoimmune disorder. The thyroid gland can be totally destroyed by an immune process. It's also the major cause of goiters and, as I said, hypothyroidism in adults and children. It is predominantly seen in women, so there's a ratio of 5-to-1, right? 5 women to every 1 male. I actually have Hashimoto thyroiditis. Funny enough, it came about after I had my 3rd child, so postpartum. So at first they thought that it was pregnancy-related thyroiditis, and it never went away. So then with some testing, it did turn out to be Hashimoto. If anyone ever wants to feel a goiter, my neck is a good one because I do have a goiter, and it is more enlarged on the right side than the left. I actually just went and had a thyroid ultrasound done to make sure everything was okay, and of course it was, but because that right side is larger than the left, they were a little concerned. Some manifestations of hypothyroidism. I always like to tell people that with hypothyroidism, everything slows down except you gain weight. And so there's a gradual onset of weakness and fatigue. Weight gain, even though you lose your appetite, you still are gaining weight. Cold intolerance, dry, rough skin, may even be a yellowish color. Coarse, brittle hair. You might see a puffy face with edematous eyelids. Thinning of the outer third of the eyebrows, which I actually did not know until I was reading the patho book. And funny enough, I have that. So everybody look at my eyebrows on Wednesday. And then fluid accumulation in the middle ear. If untreated, this can cause conductive deafness. Decreased GI motility, so things like constipation, flatulence, and abdominal distension are seen. Bradycardia, delayed deep tendon reflexes, and some CNS manifestations such as mental dullness, lethargy, or impaired memory. So again, as you look through this, everything slows down except weight goes up. When in a severe hypothyroid state, you might see that enlarged tongue, hoarse and husky voice, carpal tunnel, impaired muscle function, stiffness, cramps, and pain, pericardial and pleural effusions, and bradycardia and decreased cardiac function. And the reason behind this is because of, sorry about that, got distracted. All right, so the reason behind all of these manifestations is because of myxedematous fluid that collects in the interstitial spaces. A very serious result of severe hypothyroidism that can happen is called a myxedematous coma. It's life-threatening, and it's an end-stage expression of hypothyroidism. Occurs more commonly in the elderly. The patho of it is that it involves 3 major aspects. So carbon dioxide retention and hypoxemia. The second is fluid and electrolyte imbalance, and the third is hypothermia. So some signs and symptoms you might see is coma, again hypothermia, cardiovascular collapse, hypoventilation, hyponatremia, hypoglycemia, and lactic acidosis. Treatment is going to be supportive therapy, so basically managing all of the symptoms that occur, so fixing the cardiorespiratory status, repairing or replacing electrolyte imbalance, and hypoglycemia. And then, of course, you want to start thyroid replacement therapy. Diagnosis of hypothyroidism is going to come from a history, physical exam, and lab test. The lab test being T4 levels, and what you'll see is low serum T4 levels. You'll also see elevated TSH levels, Because remember, anytime thyroid levels are low, the pituitary is going to secrete TSH. And then if Hashimoto's is suspected, they will want to test for antibodies. Treatment is going to be hormone replacement therapy, and it is done using either synthetic T3 or T4, synthetic T4 being the most common. So here's an example of levothyroxine, and we'll talk more about medications when we talk about this in pharmacology. But another thing you'll want to do is when somebody's undergoing treatment, you're going to want to make sure that it's adequate. Dosaging usually takes a while to get right where you want it. And then even if it's right where you want it, maybe a year from now, it might be low again. So people who have hypothyroidism have a lot of testing done throughout their life to make sure their medication is where it needs to be. And the way they do this is by looking at serum TSH levels. This is going to bring us to hyperthyroidism. Hyperthyroidism results when tissues are exposed to high levels of circulating thyroid hormone. Age of onset is usually between 20 to 40 years. It is greater in white and Hispanics than African Americans. Some causes are going to be hyperactivity of the thyroid gland, with Graves' disease and diffuse goiter being the most common. Diffuse goiter meaning that it's not nodular, it is just all enlarged as a whole. And then multinodular goiter, adenoma of the thyroid gland, and thyroiditis are other causes of hyperthyroidism. A little more on Graves' disease. It is an autoimmune disorder. It was named after the British surgeon, Dr. Graves, that discovered it. And it is characterized by abnormal stimulation of the thyroid gland by thyroid stimulating antibodies that act through normal TSH receptors. Onset, just like hyperthyroidism in general, is around 20 to 40 years, with women being 5 times more likely to develop it than men. There is a genetic link. Some of the manifestations you see is the triad of hyperthyroidism. So you see a goiter, you see exophthalmos, which is bulging eyeballs, and you see dermopathy or pretibial edema. And here is a picture of the dermopathy. So this is someone who has Graves' disease. Manifestations of hyperthyroidism as a whole, you might see nervousness, irritability, restlessness, and fatigue. So basically, it's all the opposite of hypothyroidism, right? You can think of it as the metabolism revving up. So everything is going to be increased, weight will go down. Weight's going to go down, or you're going to have weight loss even though there is a large appetite because the metabolism is on overdrive. You're also going to see tachycardia and palpitations, shortness of breath, excessive sweating and heat intolerance, muscle cramps, fine muscle tremor, the exophthalmos, again the bulging of the eyeballs. There's a picture of that here. Infrequent blinking, so it looks like they're staring. Thin skin and hair, and then you might see, or it might lead to, a thyroid crisis, also called a thyroid storm, which is an acutely exaggerated manifestation of a thyrotoxic state. And we have a slide on that in a little bit. So here's how you diagnose hyperthyroidism. TSH, increased free T4, radioactive iodine uptake. So the test is going to show increased uptake of the radionuclide. You see moderate uptake in Graves' disease, high uptake in nodular disease, and a lower uptake in thyroiditis. With your TSH levels, you're going to see them decreased. And then you are going to see increased T4 and T3. Treatment of hyperthyroidism is going to be targeted at inhibiting the thyroid synthesis. And this can be done by using drugs or by destroying the thyroid tissue. So drugs that do this are termed anti-thyroid drugs, and they may be continued anywhere from 6 to 15 months. They also use large doses of iodine. Again, this is not used for long-term use. And beta blockers offer the symptomatic relief. So relief from the things like the palpitations and increased heart rate and stuff like that. The method that destroys thyroid tissue is going to be radioactive iodine therapy. But this takes a couple months, around 2 or 3 months, to start seeing effects. It is the most common treatment, though, when compared to surgical removal. So the surgical option is done only when patients aren't candidates for other therapies. They usually don't remove the total thyroid. They do a partial thyroidectomy. And they found that if you leave 10%, that's all that needs to be left, of the thyroid gland, it will regenerate, and the hope is that it regenerates normal, and it usually does. So a little more on the thyroid storm or thyroid crisis. Again, it's extreme form of thyrotoxicosis or hyperthyroidism. It is life-threatening. It is pretty rare, so usually seen in undiagnosed hyperthyroidism or people who do not treat their hyperthyroidism. It can be precipitated by stress, infection, diabetic ketoacidosis, physical or emotional trauma, and during a thyroidectomy. There are high mortality rates associated with this, so it's something you really want to prevent. Manifestations, you're going to see a very high fever, extreme cardiovascular effects, so extreme tachycardia, angina, and heart failure, severe CNS effects, agitation, restlessness, and delirium. Treatment is going to be peripheral cooling, so they'll use cool packs and a cooling mattress. Fluid, glucose, and electrolyte replacement, beta blockers, glucocorticoids, and antithyroid drugs. And finally, this last slide is just to provide perspective on the spectrum of the disorders related to the thyroid gland. So you've got your severe undersecretion causing myxedema coma, and then undersecretion, hypothyroidism, homeostasis or normal function is euthyroid, oversecretion, hyperthyroidism, and severe oversecretion, you see a thyroid storm. So this is going to be the end of the second part, or the patho of the thyroid, and then stay tuned for the third section, which is discussing diabetes.